All righty. Good afternoon, everybody. Thank you so much for attending this talk today. I'm Dr. Ryan Bennett. I am a clinical neuropsychologist here at NSU, board certified in assessment psychology. So one of the roles I have here at NSU, of course, is I'm an assistant faculty. But in addition to that, I am the team neuropsychologist for NSU athletics and a consultant for Broward County and some local sports teams. So with me being a neuropsychologist, especially in the athletic world, my primary role is concussion management, which really brings us to the presentation today. So we have a presentation going. I'm on a couple different monitors here. So if you see me turn my head to the side, just looking at the desktop here, getting through the presentation. So let's get it started. So today's presentation, it's get your head in the game. So we're going to be talking about the role of the clinical psychologist really in sport-related concussion and concussion management. Now, as I'm sure many of you are aware, as psychologists, we understand the intricacies of human mind, behavior, emotions, functioning, things of that nature. But how often do we really think about the brain itself? How often do we think about its vulnerabilities? In the athletic world, thinking of the vulnerabilities on the field, right? How the impact of really just one blow and the invisible repercussions that it can have and that can follow from that injury. And so this is what we're talking about with concussions, recognizing that these are invisible injuries to a degree. There's physical components as well, but they also disrupt things that we can't see, cognition, emotion, identity. And so that's what we're gonna jump into today. We're gonna go beyond that playbook, and we're gonna talk about really the role of the clinical psychologist in treating this diagnosis. So our playbook for today, we're gonna jump into talking about the role of the clinical psychologist, of course. With me being a neuropsychologist, of course, I got to drop in some neuropsych assessments of how we can use the qualitative data that we gather from the interview and pair it with the quantitative assessment data through the evaluation. We'll talk about how those actually interplay quite nicely with the management and treatment process. And then we'll briefly touch on some evidence-based interventions. We'll talk about what the current literature suggests at this point in time. Also, I love throwing in some trick plays with concussion. There are so many myths out there about concussion diagnosis, management, all of the above. So we're going to address those so that we're all on the same page on what these trick plays or what these myths are. We're also going to talk about the team that goes into concussion management, all of the different disciplines that go into the recovery process. And then we'll end with a post-game recovery, talking about those longitudinal implications and recommendations. So before we really jump into the role of the clinical psychologist, there we go. I want to talk about the definition of concussion, right? So Mayo Clinic, they talk about concussion. They define it as a mild traumatic brain injury that affects brain function. So pretty straightforward to the point there. The NIH, they have a little bit more jargon going on here. So a concussion is traumatically induced transient disturbance of brain function. The CDC defines concussion as mild traumatic brain injury. It's a complex pathophysiological process affecting the brain induced by traumatic biomechanical forces secondary to direct or indirect forces to the head. So we get a little bit more in depth here. And then, of course, coming in strong, APA, they give us a fairly long definition here of concussion. And they, as we psychologists like to do, we love to give as much context as we can to everything. And so the definition through the APA is it's a mild injury to the brain due to the mechanical trauma or deceleration injury, disrupts brain function, but it's typically followed by spontaneous recovery. Concussion usually involves at least brief unconsciousness, although it may be diagnosed in the absence of unconsciousness. It's actually not 100% true. Less than 10% of cases of concussions actually result in unconsciousness or loss of consciousness. But they continue on. The symptoms may include memory loss, headache, irritability, inappropriate emotional reactions, changes in behavior. So again, we're getting way beyond just the physical presentation here. And then also concussions may be classified by severity based on the period of unconsciousness or the extent of memory loss or events of the events before or after the trauma. So really what we're getting at here with all of these different definitions is it's really talking about one of the greatest challenges that we have in treating concussions. And one of the greatest challenges, it's the sheer variability in how the injury itself is defined, right? So there's over 40 different definitions in the medical literature actually for concussion, which now makes concussion become more of a moving target, if you will. And so when we have this moving target of a diagnosis, well, now it's going to become more difficult to diagnose, even harder to find this standardized assessment or treatment protocol for concussion, and almost nearly impossible to track effectively across clinical situations or research studies and things of that nature. So really this lack of consensus, it's complicating everything from the initial assessment to long-term care and leaving all of us clinicians almost an individualized approach of how we can navigate this, right? And so when we talk about concussions, I'm going to dive into this in just a little bit, but with all of this variability, this is what I really try to emphasize to any discipline I work with, any students that I work with, is recognizing that we're always treating the patient, not the diagnosis. So I'm not just treating the concussion, I'm treating the patient. Because you can find if you just treat the diagnosis with so much variability in what this diagnosis even is, we're almost functioning as if we're wearing these blinders, if you will. And there's going to be so much valuable information that we miss regarding the patient and their individualized experience. Alrighty, so we have somewhat of a definition of what a concussion is, but I really wanted to break down a little bit more from the clinical psychologist role of understanding the signs and the symptoms, right? Recognizing signs are what we would observe and symptoms what our patients would be reporting to us. So some of the common signs, the individual, the athlete having difficulty recalling events, remembering events, whether it's before or after the injury. They could appear dazed or stunned. They could forget instruction. So just giving them simple instruction. You can see this also through the assessment procedures. They could appear confused, not really understanding their surroundings, mildly disoriented, having slow processing. These last two, slow processing, and then the mood, behavior, and personality changes. These signs can be a little bit more difficult to recognize, especially if you don't have any prior experience with the athlete. Maybe the individual presents with somewhat of a flat affect at baseline, right? So these may be a little bit harder to see, but this is where collateral sources can really come in and help identifying these signs. Now, in addition to the signs, we got to look at the symptoms. So what's the athlete, excuse me, reporting to us? So headache is the number one. So the primary symptom that's reported, headache or pressure in the head, nausea, vomiting. Vomiting is arguably a sign as well. We can see that as the clinicians. Dizziness is fairly common. Dizziness is oftentimes exacerbated by the headache, along with the nausea. Double vision or blurred vision, light sensitivity or noise sensitivity. Noise sensitivity is fairly common as well, recognizing that these sport-related concussions occur in the context of a fairly loud environment. If you think of, a high school or college football game, right? Feeling sluggish or not feeling right or just feeling down. And it's important as the clinical psychologist too, to recognize how these symptoms are going to be presented to us, right? So individuals across the developmental lifespan, right, could be diagnosed, can experience a concussion. And the way that they present the symptoms are not always going to be the same, right? The way a 6-year-old presents a headache or pressure on the head, maybe they're not going to tell you that they have a headache, but they'll say their head feels funny, right? So as the clinical psychologist, we have to understand developmentally appropriate language and how our clients are sharing their symptoms with us. Alrighty. So now let's talk a little bit more about the role of the clinical psychologist here. So as the clinical psychologist, especially for those of you who have never worked in concussion management, I want you all to recognize we really bring a unique skill set to concussion management. It's beyond just the symptom assessment. It's beyond just the role of being able to diagnose a concussion. But our role as the clinical psychologist, we can look at things like the differential diagnoses, therapeutic interventions. So things such as like cognitive rehab, symptom management, providing support to the athlete and their families, ethical considerations. We're going to talk about this here in a second of understanding malingering and why athletes may exaggerate their symptoms, may underreport their symptoms, and then understanding that we need to approach and look at concussion through this culturally sensitive lens as well. And then also this multidisciplinary collaboration. But I want to take a step back just for a second on looking at differential diagnosis, because in the clinical world, this is something that I think we bring a lot to the table. So when we're thinking about us playing this crucial role in concussion management with differential diagnosis, we're looking at essential ways of distinguishing between symptoms of a concussion and overlapping pathologies or conditions such as depression, anxiety, maybe some neurodevelopmental disorders, ADHD, things of that nature. Because many of these symptoms are shared. Many of these disorders share common symptoms. Things like inattention, feeling down, concentration difficulties, fatigue, right? And what this can do is it makes it easy to misattribute the symptoms of the concussion to something else that may be going on, right? So we need to recognize, again, this is why we treat the patient and not just the diagnosis, because in the context of treating the patient, well, maybe they have pre-existing history of major depression. Maybe they have generalized anxiety. Maybe they also have ADHD, for example. All fairly common diagnoses, especially in the clinical world. And these individuals, when they have a concussion, now as the clinical psychologist and the neuropsychologist and working with concussion, we have to find a way, how do we tease apart these symptoms? How do I attribute what is actually going on due to the injury of the concussion versus the pre-existing symptoms that are there, right? And it's not this dichotomous yes or no of the symptom presentation, but possibly symptoms are being exacerbated, right? Well, maybe the concussion is now exacerbating their mood changes, right? Maybe they're feeling even more irritable, right? Maybe it's further exacerbating their concentration difficulties. So all of these things are just very important for the clinical psychologist to be aware of and recognize. Again, I'll say this 100 times probably in this presentation, but recognize that we are treating the patient, not just the diagnosis of concussion. We're managing the patient care, not just managing the concussion. And then again, like we talked about, therapeutic interventions. We'll talk more about that in a second here on some cognitive rehab, symptom management, psychoeducation. With the ethical considerations, malingering, especially you hear this more in like a professional context, where the common term, at least in the NFL, is sandbagging. This was a very hot topic, maybe about, 5-10 years ago, of athletes coming in, performing poorly on cognitive baseline assessments and things like that. And we have to recognize what's the motivation for an athlete to not give their best effort, right? Or to minimize giving their best effort on assessments, or to minimize their symptoms in the first place, right? I see this all the time here at NSU, and this is where psychoeducation really comes into play, because athletes will present symptoms in one way to me of they feel 100% fine, but then my testing is showing that they're far from 100% fine. And when having that discussion with them, maybe their team is going into playoffs the next week. Maybe they're afraid of losing that varsity spot and losing their starting position. So we have to really provide the psychoeducation of the recovery process of a concussion, and really emphasizing that, you're going to play in multiple games, but we only get one brain. And so that usually resonates with the athletes, and especially with their families. Now, in addition, multidisciplinary collaboration. This is one of the things I absolutely love being a clinical psychologist and neuropsychologist in the role of psychology and concussion management, is working with all of the phenomenal disciplines that there are. So here in the sports med clinic, My office down the hall, there's 4 of us in one fairly large office. And so you have myself as the clinical psychologist, and then to my right, I have our physical therapist, Dr. J. Behind me, I have Dr. Isaac, our physiatrist. Cat corner to me, I have another sports med physician. So it's really great collaborating with all of these different disciplines because we're all working with the patient, and we can all provide our individualized assessment, but then collaborate as a treatment team and providing the best care to the athlete. All righty. So we talked kind of about that qualitative piece here, but now let's get into the quantitative structure of neuropsych assessments and how that's so important and why it's so important. Some of you may have heard of the IMPACT test, the immediate post-concussion assessment for cognitive testing. Widely used test. It's a computerized neurocognitive assessment tool. It was designed specifically for concussion management, which is great. It looks at different domains such as memory, reaction time, processing speed, things of that nature. Now, one thing that's really cool with IMPACT is before the season, athletes will take this assessment. So they're deemed their baseline assessment. So that way, if they have an injury, if they have a concussion throughout the season, we can compare their performance on IMPACT to their baseline, their preseason performance. And that can be one data point that can help the clinical psychologist guide us towards, is this athlete recovering appropriately, or are there other barriers that we need to address? Now with IMPACT, another interesting piece with it, there's different versions. So you may be thinking of, are there practice effects if they're just taking the same test over and over? Great question. No, not really. There's 5 different versions of IMPACT. So with that, the athlete is getting the same cognitive domain assessed, but without being able to practice and remember the items. Now, another assessment is the R-bands. This is the repeatable battery for the assessment of neuropsychological status. R-bands is also, it's a good assessment. Looks at serial assessment, especially. So there's different forms. You have, version A, B, C, and D. This looks at different things like visual spatial abilities, language, attention, memory, things of that nature. So all of these things can be valuable in assessing for concussion in the recovery process. Trail making test. Now the original, trail making test has part A and B. I'm actually a big fan now of the DKEF's trail making test, where there's 5 conditions. It gives me a more detailed picture of what's going on with the athlete's executive functions, and making sure that I'm addressing and assessing that cognitive domain of executive functioning. So for that assessment, there's 5 different conditions. The first one is just a visual scanning. The second is number sequencing, so connecting just numbers together. The third condition is letter sequencing, so connecting the letters. And then condition 4 really gets at that task switching executive function component, where the athlete has to connect number, letter, switching back and forth. So they'd have to go 1 to A, to 2 to B, to 3 to C, and so on, all the way till they get to the end. And then the last condition, condition 5, is just a motor sequencing, looking at their speed. The reason I kind of walk you through those conditions is because I actually just had a case a couple weeks ago where I was evaluating a child, and I gave DKEFs, and I got to condition 3, which is the letter sequencing, and the child didn't know their alphabet. So that was not fluid to them. That was not an automatic process. Therefore, if they don't know the alphabet, then I can't give them condition 4, looking at task switching, because they're not going to be able to complete it because they don't know the alphabet. So it's a great example, I think, of make sure the assessment that we're using truly assesses the cognitive domain that we're looking at. So in that example, executive functioning, because if I would have just given that condition 4, well, their performance would have not been very good because they don't know the alphabet. But one may look at that scaled score and say, oh, poor executive functions, when in actuality, I didn't actually assess for executive functioning. It just told me more about their academic ability or inability. The Stroop test is another really good test I like to use. This really gets at that inhibitory control of that automatic response of wanting to read the word and not tell me what the color of ink is that the word is printed in. So that inhibition, that ability to have that cognitive control is oftentimes impacted with concussion. So this is oftentimes a good assessment to use. And then effort measures. I don't always use effort measures such as like an outstanding one like a TOM. Embedded validity indicators are addressed. Impact itself has embedded validity indicators. So I'd only really use an effort measure, an external effort measure if I was concerned with effort. Now, I'm not a representative of SportGate, but I really like SportGate. Doing some research with them now. We're starting to see this transition, and we're starting to see Impact. Impact has been around for decades, and they essentially were monopolizing the industry of concussion assessment because it was so streamlined for assessing for concussion. But now we're seeing some other competitors come into play, and SportGate is a big one. SportGate kind of breaks down the assessment process. One thing I really like about it is it looks at the neurocognitive assessments in conjunction with the neuromotor evaluation, in addition to tracking symptoms over time, and then also providing those educational resources and check-ins for the patient. Now, the cognitive assessment that they use here, it's a shortened version of the CPT, which is the Conners Continuous Performance Test. This is where the athlete has to hit the space bar or tap the screen on their phone whenever they see a letter, except for the letter X. So it shows that inhibitory control there. And somewhat sustained attention, but again, it's only about 7 minutes long. Then it also does a neuromotor evaluation through a biokinetic feature, which assesses balance and motor function. And then again, tracking their symptoms over time. So SportGate, very similar to Impact, has a baseline feature of preseason, and then you can utilize it after the athlete has an injury. So we could use this as another data point to refer back to track the recovery process. Now, I realize not everybody on this call, on this meeting, is a neuropsychologist, but it's important for the role of the clinical psychologist to understand what are the assessments that are being used, because it's very rare for a client or a patient to come in with a concussion and not receive any psychological or neuropsychological assessment, or a cognitive screening or a physical screening, right? So I wanted to share these with you all because these are some of the heavy hitters that are currently being used. All righty. So some of the evidence-based interventions for recovery, what we're seeing here, cognitive behavioral therapy for things like, anxiety, depression, commonly used. Sometimes when the role of the clinical psychologist with concussion management, sometimes I see myself acting almost like a CNL service, like a consult liaison, because I'm addressing the concussion and helping the patient get connected with resources, whether it's at Henderson or College of Psychology or other sources in the community. So kind of acting as that bridge, but recognizing for anxiety, depression, these emotional concerns, CBT is the front runner for this concussion management piece. One reason being for CBT is it's very skill-based and skill set and structured. For cognitive rehab pieces, things like attention, memory, helping improve those skills through just general rehab tasks, helping the athlete modify their day so that they can be more effective. Maybe it's setting reminders throughout the day or whatever they may need. And then psychoeducation is arguably, I think it's the most important piece for symptom management. Looking at the risk, the short-term risk of the injury and returning to play too soon, and the long-term risk of, I've had X many concussions, talk to me about kind of the education on what I should do moving forward. Psychoeducation is meant to be informative and used as a guided tool. We're providing the education to the patient. We're not telling them, right, on how they should move forward. It's not a fear-based tactic, although sometimes the interesting thing is parents can make it feel that way, especially when you're evaluating a child with a concussion. I had a mom the other day, her son had a concussion, and she said, tell him how he's now going to get CTE because of this concussion. I was like, well, let's take a step back here. Not going to get CTE per se, but here's some of the education surrounding of concussion management. So we have to really kind of monitor what's being talked about in the community and the fear that's surrounding this injury, especially lately with what's going on in the National Football League and things like that. Alrighty. So as clinical psychologists, I wanted to take you all back to your first year of grad school here for a minute, and let's talk about this biopsychosocial context in evaluating concussion and being a part of that concussion management team. So with that, I want to talk about, just for a minute, the cognitive components of concussion. We're going to talk about some of the emotional features, the behavioral features, and the physical features as well. And when we talk about the biopsychosocial component as well, we got to understand the patient's medical history leading up to the injury, social functioning, interpersonal functioning. All of that is very important in giving a comprehensive and conducting a comprehensive evaluation. All righty. So neurocognitive changes, kind of touched on this with some of the assessments, but looking primarily changes in one's memory, attention or concentration, changes in their reaction time, changes in their processing speed. And one thing I think it's important for the clinical psychologist to be aware of here is recognizing that when we're working with athletes, things like reaction time and visual processing and things like that are probably going to be high anyways. They're going to be strong in those categories. So we got to compare the individual to the individual, not to a normative group, possibly that's where we wouldn't see reaction time being elevated. An example I have of this is I was working with a soccer player a couple years back, and they were going into playoffs, and he was 1,000% convinced that he was recovered. I don't know if he was actually convinced, but he's trying to convince me, which is never a good sign when the patient is trying to convince you as a psychologist that they're good to go. So denied all the symptoms, everything was great. And again, he's a goalie, so I did some assessment. I think we went through impact, and his reaction time came back to, he was in the first percentile for reaction time, which is extremely low. His baseline was like the 89th percentile. And so I went and talked to him, and I said, well, this could mean one of two things. One, maybe we're not going to do so great in playoffs if your reaction time is really in the first percentile, or two, which is more likely, you're still experiencing symptoms of the concussion and need more time to recover. And at that point in time, he then reported his headache. He reported how the lights in the office were bothering him. So he became more open and honest when I was able to correlate what he was sharing with me and highlight the inconsistencies of what the data was showing. All right, so that's some of the neurocognitive changes. Some of the emotional changes, we see things like irritability, increased levels of anxiety, increased levels of depression, especially if there's pre-existing anxiety, depression, right? Like we talked about earlier, it could exacerbate those pre-existing pathologies. Hypervigilance as well. Hypervigilance, you see more, I've seen more, I guess, in my clinical practice, more of concussion, not sport related, more of like motor vehicle accidents. I see increased rates of hypervigilance and acute stress following being in a motor vehicle. But some of these emotional changes, they pair nicely with the behavioral changes that we see, and we're looking for consistency. So as the clinical psychologist, I'm looking for things that are consistent, that are congruent, and those emotional changes go right in line with these behavioral changes of things like low energy, sleep difficulties, low motivation, feeling more isolated. And if we take a step back from being a clinical psychologist and try and look at this through the lens of the athlete, this makes perfect sense. You have to think about this athlete just endured or just experienced this injury, right? And so now everything of their day-to-day is going to change for a little while in relation to sport especially. So yeah, maybe they are going to feel more isolated or have low motivation. Maybe they're feeling isolated because now they've had a concussion and now they're removed from the one environment that they have worked so hard to be in, right? Especially when you're talking about varsity levels in high school, when you're talking about professional sports or collegiate athletes. I'm removing them from an environment that they have worked arguably their entire life to be in, right? And now for some of my athletes, depending on their symptomatology and their presentation, I'll tell them, I don't even want you to attend practice, or I don't even want you to go to the game on Friday or Saturday night, right? Because if they're having visual disturbances, if light sensitivity, sound sensitivity, easily fatigued, headache, right? Well, then I don't want you standing on the sidelines, even if you're just observing this big event of whatever game it may be. So of course they're going to feel isolated. Of course they're going to have low motivation. Now they're not exercising near the amount. They're not putting their body through the exertion of sport, which they were doing every day. So maybe they're going to have more difficulties falling asleep with sleep onset or maintenance and just overall low energy. So it's important, and again, this is where the clinical psychologist really comes into play here, is recognizing we can look at the physical symptoms of the concussion. I can watch the video of the injury and tell you pretty confidently whether or not a concussion was happened there. But it's what we don't see with the concussion. It's the invisible features of a concussion where the clinical psychologist really comes into play. What's not being shown? Yes, we see the injury, but do we see the isolation? Do you see the sleep difficulties? Do you see the depressed mood? Do you see the anxiety, right? And those are features that the clinical psychologist really needs to be open to and explore. And that's the value that can really be added to that multidisciplinary team. In addition, physical changes. So, kind of all correlating here. Headache, nausea, head and neck pain, numbness and tingling. Going back to this teamwork approach we were talking about earlier, and we're about to talk a little bit more about here. I love the office that I work in, because if I evaluate a patient and they're having some neck pain or maybe some numbness or tingling, I can turn right to my right and say, Dr. J, who is our physical therapist, can you go in and evaluate the patient? So they get this on-site care from all of these different disciplines, which makes it really comprehensive. All righty. So now I want to talk a little bit about just the teamwork approach in general, and the approaches that are currently used with concussion management. Not uncommon to see a disciplinary approach. Maybe it's just the patient's primary care physician treating the concussion, or multidisciplinary, where they go to see their primary care and then they refer to a sports doc or a specialist. Interdisciplinary care is where we start to really see this overlap here, where maybe the primary care is working with a neuropsychologist who's working with the physiatrist, and we're all working in congruence together. And then where the literature has been going the last couple of years is really emphasizing transdisciplinary care. And the main addition to this feature is recognizing that the patient is the number one most important member of the treatment team. So it's not the providers talking about what's best for the patient. It's including the patient as a part of being a member, a crucial member of that treatment team, and having the discussions with them regarding their injury, recovery process, and recommendations. All righty, so here's our team currently here at NSU. You can see which one of us was not available for headshot day from this. But this Dr. Posey, she's at a different facility now, but was recently our team physician. Dr. Isaac is our team physiatrist. Dr. J is our physical therapist, and I'm the neuropsychologist, of course, and the clinical psychologist, playing into this comprehensive care for our athletes. All righty. So I want to see if I can pull this up here. I wanted to walk through this for just a second with you all. As a clinical psychologist, I feel like this could be really helpful of understanding, well, what are we doing? So you do this evaluation, you understand this injury happened. What do you recommend? Where do we go from here? So I'll try and zoom in on this. There we go. So at the end of every session, which I see my patients once a week, once they had a concussion. So I'll see them every week, monitoring their recovery, more if needed, but at least once a week. And at the end of their appointments, they leave with a document that looks very similar to this that I can click and kind of check off. So the considerations that we're looking at here, looking at attendance. So are you recommending that they stay out of school, including things like online classes? Are we recommending a partial school day? So as tolerated by the student, emphasizing, core subject work. If I'm recommending a partial school day, then I'll recommend maybe the morning session, first half of the day on one day, and then the next day do an afternoon so that they're not missing too much of their core work. Or a full school day as tolerated. So these are things that we have to consider. Breaks. So if they start to become symptomatic during their classes, allowing them to have these mandatory breaks. The visual stimulus, so pre-printing their notes if they need, limiting that computer tablet time. Now, this is an interesting myth that I don't have on this presentation. You really don't want to limit screen time too much once you're about 48 hours post-injury. So when you're more than 48 hours post-injury, I want them to start using screen time as appropriate. I don't want, especially with pediatrics, I don't want the kid to go home and play video games for 8 hours straight, right? But I also don't want them not looking at computer, tablet, phone, if that's what they tend to do in their day-to-day. Because if they are now restricted from using that for the next couple of weeks, well, now it's going to be a flooding effect of when they start using that device again. So again, you limit it up to the first 48 hours. After that, we start getting a gradual introduction to those devices. Allowing handwritten assignments and exams. Student can wear sunglasses in class, a hat in their class, seating away from windows or bright light. These are all types of considerations that the clinical psychologists we have to think of because this could exacerbate their symptoms in this environment. Changing the classroom seating to the front of the room if necessary. Parents love that recommendation. Kids hate that recommendation. No child wants to sit in the front of the classroom for some reason. Auditory stimulus, so avoiding loud classroom activities, loud classes and places, allowing them to transition 5 minutes before the bell, especially in like a high school environment, right? So again, these are things that the psychologists were thinking, almost think of this as the ecological validity of how are these recommendations, how is this treatment going to transition into their day-to-day. For schoolwork, reducing in-class work, prorating the workload. So usually what I'll say is, some teachers will give, pre-algebra, like 100 problems to do. Well, maybe we're only going to do what's needed. So kind of a segment of that and working with the teachers on prorating that workload. Do they need to not have homework at that time? If they are going to have nightly homework, how many minutes per class are they going to do a night? How many minutes in total? And then if they need additional tutoring as well. Testing, I'll either start with no testing, giving additional time for testing, alternative testing methods, whether it's an oral delivery of the questions. I'll recommend, this is all dependent on the patient's presentation, of course, no more than one test a day, no standardized testing, and then eventually at the end, resuming normal testing. And then as far as physical activity, you may be wondering, why is this at the end, right? When you think of a sport injury, that kind of being the first thing that kind of pops into the brain. The guidelines suggest, and what we follow is there's always a return to learn before return to play. So the athlete needs to return to their full academic environment, occupational environment, this cognitive load before they return to their sport. Now, I'm not saying that they need to be isolated in a room, not doing anything physical, right? We always recommend so light exercise, cardiovascular exercise as is appropriate, and you progress that as they're recovering, but they're never returning to sport with unrestricted play until they have a full return to learn or their cognitive functions. All righty. All right. I'm going to pause just for a second before we go into the trick play. I see something in the chat here. As a psychologist, do you use the same CPT codes as other providers? When is the best time to administer testing after the event? Great question. Using the CPT codes, of course, this is all dependent on the environment that you are practicing in. But yes, the general CPT codes, standard ones for psychology, are used. Best time to administer testing after the event, it depends on how quickly the athlete comes to you. So there's an assessment called the SCAT, which is a sideline concussion assessment tool. And usually athletic trainers give that assessment. They can give it on the field to evaluate. And if it's more than 48 hours after the injury, then it would transition to something called the SCOT, which is the office version of that concussion evaluation. But usually I'm seeing the athletes come into my clinic usually 2 days after the injury, because the primary referral is they have the injury, they either go to the ER where they get a CAT scan, which is usually negative, and they get discharged from the ER. They'll follow up with their primary care the next day, and then they're coming to a concussion clinic usually the following day. So I'm usually seeing them probably 2 to 3 days after the injury. Alrighty, so trick play, you have to lose consciousness to have a concussion? Of course not. Actually, like we talked about, only about 10% of cases result in a loss of consciousness, and it's usually fairly brief. Another trick play, you can return to play once you feel fine. No. Even when symptoms subside, right? Maybe the athlete is truly not experiencing symptoms such as headache, light sensitivity, things like that. The brain may still be in a vulnerable state. So returning too soon can really increase the risk of having a second concussion. We're not going to talk too much about it, but I want you guys to think of Tua's injury a couple seasons back. Tua being the quarterback for the Dolphins, where he had an injury on a Sunday night, a concussion, which I think they ruled a subconcussive event, and he did not have time to fully recover. So then he went and played Thursday, just a couple days later, and had what arguably may have been a subconcussive impact, right, but resulted in fairly catastrophic symptoms or presentations of a concussion. So fortunately, he did recover, right? But if we don't allow the brain to fully recover, it's going to be in this vulnerable state where you are going to be more susceptible of experiencing not only a second concussion, but one with more severe effects, such as that case. Helmets prevent concussions? Absolutely not. I have an interesting qualm with helmets. There's so much engineering that goes into helmets, but what I'm seeing with my athletes is the better the helmet, the more willing they are to use their head in contact because the helmet is there. So it's providing this false sense of security, if you will, to some of the athletes, of saying, you know, the helmet has all of this padding, so I can use my head for sport, which is definitely not the case. Helmets do help with other types of head injuries, especially like skull fractures, things like that. However, the brain can still shake within the skull, even if you're within a helmet causing that injury, causing that concussion. Children recover faster than adults from concussions. This is something for the clinical psychologist to know. This is a myth. And it's really important because oftentimes when you're working with sport-related concussions, if we're not working with professional athletes, then you're working with youth. So this is really critical to share with the parents. I don't know how many of you have heard, I hear this all the time of, oh, he's a kid or he's young, he's going to recover in no time, right? Which again, now almost sets this expectation for the client that they need to recover at a certain rate, or that they're going to be returning to play prior to their full recovery. So children and adolescents actually often take a little bit longer to recover from a concussion than adults. On average, just under 3 weeks. Their brains are still developing, which can make them more susceptible to the effects of concussion. And so we need to recognize, they also have difficulty recognizing the symptoms, which can delay diagnosis and treatment. So we just need to be aware that children, just because they are young, they are not going to be recovering faster than adults from concussion. All righty, so kind of ending this presentation here with just some post-game recovery knowledge. recognizing the median length of recovery is about 17 days for pediatric sports. I don't like to tell my patients a given recovery time frame, because recovery is a process. Recovery is not a day. I don't want to set them up for failure. I want to set reasonable expectations. So on average, you're looking 2 to 3 weeks for a concussion, but that doesn't mean that an individual could take 3.5 weeks, could take 4 weeks. It's all dependent on so many different factors of how many concussions they've had in the past. Are they adhering to our recommendations? What was the severity of the injury? So there's so many different factors that we have to consider that I don't like to tell patients, oh, you'll be recovered in a couple days, because that is definitely not the case. Once someone has experienced a concussion, they're 4 to 6 times more likely to experience another concussion. And so it's exponential. It just keeps increasing and increasing. So you can imagine by the time you get to 3, 4 concussions, the level of injury or impact that it would take to result in a concussion is going to be less each time. The more concussions you experience, the greater risk for suffering from long-term effects, things like post-concussion syndrome. Again, CTE is a hot topic right now, especially when you're talking about the NFL. That's time for another presentation of really diving into that. But just recognizing that the more concussions you experience, the greater you are at risk for having these long-term impacts. Sharing, recovery is a process. It's not a day and time. Sometimes, you have patients come in and they'll say, okay, well, I see you today, so can I play tomorrow? And, we really just got to set those expectations. And again, treat the patient, not just the injury. This is so important, because we can find ourselves as the clinical psychologist sometimes maybe putting our blinders on of looking for that diagnosis, especially in a clinic where I'm treating primarily concussion, right? Of just having the blinders on and focusing on the concussion. If I treat just the concussion and not the patient, I'm going to lose so much information about the patient. If I treat the patient and not just the injury, well, guess what? The diagnosis is going to come into play, because I'm working with the individual as this holistic being rather than as this isolated injury, if you will. All righty, so that's what I got for you guys. I'm happy to address any questions that you may have. Thank you all so much for attending this presentation. I can put my email in the chat as well. And that way, if you have any additional questions or follow-up, please feel free to email me or contact me. Hey, Allison. Yeah, I can email you. I have your email, so I'll send you over the CPT code list, because we just updated that in clinic. So I'll send that over to you. All right. For referrals, what is the best contact? Are you talking about for patients in general for referrals, or you're talking about the contact information for our clinic? Let me know and I can guide you on that. Oh, for our clinic. Yeah. So we are the it's NSU Sports Medicine Clinic. I'll put that in here. And if you give me 1 second, I will give you the direct line as well. All right, I'm going to put that number in there for you. And I'll re-add my email as well. All right, so that's the number to our clinic. So that'd be the best way to get in touch with our front office to schedule an appointment. And that is my email. Thank you, Carlos. just going to check, see if I missed anything else. Kadenia, hello. Long time no see. How often do you neuropsychologically assess the patients after they're diagnosed with a concussion? Really until they return to baseline. So once they return to baseline on my cognitive testing, that's always a good checkpoint to use. Again, that's always going to be used as a data point, not a defining definitive answer of they're fully recovered. But once they return to that cognitive baseline and they're functioning fully in their academic environments, meaning they're not getting any accommodations, no extra time, no accommodations at all academically, then I know that they're recovering nicely to move forward with that physical return to play. Yeah, I can email, Nisha, I can email the presentation to Carlos, and happy to share that with you all. And then I think Carlos posted my email, so hopefully you're able to see that. I don't know why it's not coming through. Alrighty. Well, we'll get the handouts, and I'll make sure everybody has my email. Make sure I didn't miss anything else in the chat. Alrighty. Well, thank you all again. Have a great rest of your day.